Now that we finished talking about lipid-lowering drugs, let's move on to discuss some of the drugs used in treating heart failure. The first group is known as cardiac glycosides, including digoxin and digitalis. These drugs work by directly inhibiting the sodium-potassium ATPase in cardiac muscle. This increases the intracellular concentration of sodium, which then increases the exchange of sodium and calcium. The end result is an increased intracellular concentration of calcium. This increased concentration of calcium leads to increased contractility, which is why these drugs are being used for CHF. Cardiac glycosides also stimulate the vagus nerve, so they can be used in atrial fibrillation. Common toxicities include cholinergic effects, such as nausea, vomiting, diarrhea, as well as blurry yellow vision. There are important EKG changes, such as increased PR interval, decreased QT interval, and T-wave inversion and AV block. A poor prognostic marker is hyperkalemia. These side effects can be worsened by renal failure or quinidine by the mechanisms listed here. In the event of severe toxicity, known in the hospital as dig toxicity, treatment includes slow normalization of serum potassium as well as anti-digoxin antibodies. To finish up the cardiovascular drugs, we're next going to spend some time talking about antiarrhythmic drugs. There's a lot of information to be learned here, and a lot of students will find it hard to keep all the details straight. To be honest, it will take you some time to learn this information in all the detail that you need. For now, we'll focus on the concepts and make sure to come back to these topics. Before we get into any of the specifics, let's just be clear about how antiarrhythmics are categorized. These drugs are split into different categories based on how they work. Class 1 antiarrhythmics are drugs that block sodium channels. All of these drugs slow or block conduction, and they do so more effectively in cells that are frequently depolarized. All Class 1 drugs slow down phase 0 of depolarization in cardiac myocytes. Class 1 drugs are further split into subclasses A, B, and C based on the specific details of their pharmacokinetics. Class 1A drugs prolong phase 3 of the action potential, which you can see here in the red line, and this thereby increases the effective refractory period and QT interval drastically. This class includes quinidine, procainamide, and disopyramide. Class 1B drugs prolong phase 3 the least, which you can see here in blue. This class includes lidocaine, mexiletine, and tocainide. Class 1C drugs are in the middle as far as phase 3 prolongation, which you can see here, and this includes flecainide and propafenone. Because of the differences between these three subclasses, they are used in different clinical settings. You should remember that Class 1A drugs are used mostly in atrial and ventricular arrhythmias. Class 1Bs are used mostly post-MI, and Class 1C are best for life-threatening arrhythmias, such as intractable SVT, VTAC, and VFib. The next class of antiarrhythmics is Class 2, which is the class of beta blockers and includes propranolol, esmolol, metoprolol, atenolol, and timolol. These drugs work by directly antagonizing beta receptors, which decreases cyclic AMP and thus intracellular calcium. These drugs work as antiarrhythmics by decreasing the slope of phase 4, and the AV node is particularly susceptible to their action. Hence, they are commonly used in a variety of conditions, including VTAC, SVT, AFib, and aflutter. Common side effects are impotence, exasperation of asthma due to the cross-reactivity of beta-2 receptors in the smooth muscle bronchioles, bradycardia, AV block, congestive heart failure, and general CNS effects such as sedation and sleep alterations. One side effect that is very high yield for the exam is masking the effects of hypoglycemia. These drugs need to be monitored closely in patients at high risk, such as diabetics who are taking insulin. Overdoses can be treated with glucagon. How does glucagon overcome beta blocker overdose? Well, glucagon activates G protein receptors in the heart, which causes activation of denylate cyclase and an increase in cyclic AMP. This causes the sarcoplasmic reticulum to release its calcium stores, and as a result, there's an increase in SA node activity. Next, we have class 3 antiarrhythmics, which is the class of drugs that act by blocking potassium channels. This includes ibutylide, sotalol, bretylium, amiodarone, and dofetilide. These drugs work by increasing the action potential duration and the effective refractory period, which you can see here. These can also increase the QT interval. Potassium channel blockers are normally used when other antiarrhythmics are unsuccessful. Because of their mechanism of action, there are some important toxicities to keep in mind. First, any drug that prolongs the QT interval can lead to torsades de pointes, including sotalol, ibutylide, and bretylium. Additionally, amiodarone has a number of specific toxicities that are very high yield to know. These toxicities include pulmonary fibrosis, hepatotoxicity, and hypo or hyperthyroidism. An interesting fact is that amiodarone acts as a class 1, 2, 3, and 4 channel blocker, and it is 40% iodine by weight and has similar structure to thyroxine. Therefore, it can cause abnormal thyroid function with either an increase or decrease in thyroid function. Any patient taking amiodarone should be monitored with pulmonary function tests, liver function tests, and thyroid function tests. Other toxicities include blue-gray skin deposits and neurologic effects. Next are class 4 antiarrhythmics, which are the calcium channel blockers, verapamil and diltiazem. We've already discussed this class, but they work by decreasing conduction velocity and increasing PR interval. They are used to prevent nodal arrhythmias. They can cause constipation, flushing, edema, and certain other cardiovascular side effects. Finally, let's mention some other antiarrhythmics. Adenosine works by driving potassium out of cells, and it is useful in abolishing SVT. It is important to know that it is very short-acting, and it can have severe toxicity, including hypotension and chest pain. Last but not least is magnesium, which is used primarily in torsades and digitoxin toxicity. Magnesium is a cell membrane stabilizing agent and is also an important cofactor of the sodium-potassium ATPase, and as such helps keep the proper intracellular potassium levels. Further, magnesium competes with calcium to enter the cardiomyocytes, acting as a calcium blocker. Finally, co-administration of magnesium increases the intracellular potassium, hyperpolarizing the cells, making them less excitable. Congratulations, you've made it through the cardiovascular section.